Cysts are in ERCP and EUS and pancreatic, biliary, and related diseases. When I was a hepatology fellow, he was our go-to advanced endoscopist. We would always save our consults for Thursdays when he was on the Parnassus campus, which I can tell you now, because we are losing him soon to Florida. So this is our last chance to get all his pearls of wisdom. His research interests are innovative techniques in ERCP, EUS, and clinical outcomes associated with endoscopic procedures and pancreatic diseases. And so today we'll be learning about pancreatic cysts.
Thank you for that kind introduction, and to the organizers for inviting me. It's a pleasure to be here, and it is somewhat sad at the same time because this probably will be one of my last sort of events in California for the foreseeable future. That said, no better place than Monterey with friends to end it, and look forward to the next chapter. So my talk is on pancreatic cysts. I was given a pretty much broad topic, and I'll cover various aspects. These are my sort of disclosures. I do consult for various companies, and I want to acknowledge my colleague, Dr. Dai, for some of the content in the slides. When you talk about pancreatic cysts, by the way, I just realized that my title slide actually never had the title, so I apologize for that. It just had my name. When you talk about pancreatic cysts, the topics that I thought are clinically relevant that I could go over are background in epidemiology, what is the impact in our day-to-day practice, the types of cysts, diagnostic evaluation, a lot of exciting work being done, and we have Dr. Walter Park in our midst here who's actually doing some of the great work, and then guideline-based management. In terms of background in epidemiology, pancreatic cysts are common, and the more sort of imaging studies we perform, the more we find them. The majority of these cysts tend to be asymptomatic, so about 70 to 80% actually have no symptoms, and they're incidentally found. A typical story is a patient who's gone to the ED with lower abdominal pain or a possible kidney stone, gets a CT scan, and there's a lesion in the pancreas. If sometimes patients with pancreatic cysts may have vague symptoms, such as abdominal back pain, weight loss, jaundice, diarrhea, palpable mass, that may point towards the pancreas. At other times, it may be an obvious source, such as pancreatitis, which is associated with the cyst, and there's a bidirectional relationship, either the cyst causing pancreatitis or pancreatitis resulting in the cyst. So there's been some data sort of to support the overall increased incidence of cysts with aging. As we get older, we are more likely to be diagnosed with cysts. This was a 13-month study, over a 13-month period, an MRI evaluation of all asymptomatic cysts that were found. And the incidence of pancreatic cysts was noted to be increasing as the decades of age increased. Also, you will notice that in the next column over, the size of the cyst also increases. The number of cysts may slightly increase over time too. So these things do develop. They develop slowly, and they progress over time. And the other two studies listed below are also similar larger studies from Germany and I believe the US, which shows similar data. The big question is, what is the implication of these cysts? How do they matter? And this is something that's harder to study prospectively because it requires a lot of follow-up time, and there isn't much in terms of good prospective data. However, there are association data, and this study here from Tim Gardner's group essentially tried to figure this out using the SEER database, where they determined the number of mucinous neoplasms, which can be associated with mucinous adenocarcinoma that is associated with cystic malignancy, and then using this 2.5% prevalence rate in the baseline population, calculated the denominator, which would be the number of cysts based in that SEER database patient population. And what they determined was that based on the number of total malignancies that they found, what the expected rate of cysts would be over different decades of life. And as you can see, that they predicted that the number of cysts, number of patients with cysts would increase with each increasing decade. In addition, the risk of malignancy dependent on the time at the time of diagnosis in the decade and size of the cyst also would be predictive of malignancy. So we know that the cysts are there; they're increasing. They do increase with aging, and the likelihood of malignancy is higher at a higher age. So the big question becomes: well, what are we dealing with? What type of cysts do we have to encounter and worry about? So this is a nice sort of classification based on cyst lining or origin of the cyst. And if you think about it, an inflammatory cyst or a pseudocyst, which is a post-pancreatitis, typically is by definition has no lining. A mucinous cyst, such as a mucinous cystic neoplasm or intraductal papular mucinous neoplasm, IPMN, has cells that produce mucin, and these are, have the potential for malignancy. Serous cyst adenomas have a serous lining, and these are essentially benign. Similarly, squamous lining would be lymphoepithelial. Acinar coming from the ductal cells would be malignant, and then solid tumors depending on their origin. Practically speaking, I think what it boils down to is symptomatic versus asymptomatic, and really what I'm going to focus on here is the asymptomatic cysts. And if you think about them, the non-neoplastic, which is the leftmost column, is the benign cyst that we don't have to worry about. The challenge here is making the right diagnosis and making sure that we reassure the patients. So these would be the pseudocyst, retention cyst, lymphoepithelial cyst. In terms of cystic neoplasms, the one that is the mimicker of malignancy, which is actually the most reassuring, is a serous cyst adenoma. Oftentimes gets misinterpreted on imaging studies, and patients may come very worried with a large 5-6 centimeter mass, and actually it ends up being a serous cyst adenoma, and the patients can be reassured. And the ones in red are the ones that have the potential for malignancy, the mucinous neoplasms, as well as the solid pseudopapillary tumor. And on the right side, you can have cystic degeneration of a solid malignancy, which is important to remember that a cyst may completely be liquefied tumor, especially neuroendocrine tumors, and can be mistaken for, in quotes, a benign cyst, but actually is a malignancy. So pseudocysts, not exactly the main sort of group to be discussing in this forum, except to say that they can present as asymptomatic cysts occasionally, but oftentimes there is a history of pancreatitis, typically within the last four to 6 weeks, but patients can have a cyst that can be there for years and may present as a pseudocyst. By the time it's a pseudocyst, it's got a well-demarcated wall. By definition, the fluid in there should be amylase and lipase rich. And if one were to look for communication, you may find it via ERCP, though we don't need to have it. The fluid in chronic standing cysts may be dark and turbid. Early on, it may be clear. And by extension, I think, I hope everybody here is familiar with the revised Atlanta classification and knowing the difference between the different types of inflammatory collections, whether that's a pseudocyst, which is in the setting typically of acute pancreatic pancreatitis, interstitial edematous pancreatitis, as opposed to necrotizing pancreatitis, where it's acute necrotic collections, which over time will become walled-off necrosis. All these will have a high amylase, lipase, and any other biomarkers that we typically send for will be negative. Serous adenomas, these are the ones that can be, as I said, mistaken for malignancy. An anecdote, just recently, a female patient in her 60s who basically was setting up a visit with an oncologist as well as a surgeon to have her pancreatic mass removed because her husband had died of pancreatic cancer, and she incidentally had been found to have a cyst. Her CT was very characteristic, so oncology referred to us. The CT was very characteristic of a serous cyst adenoma, but it was read as a pancreatic mass with an invasion of blood vessels. So a lot of damage is already done when the pancreatic malignancy sort of diagnosis is shared with the patient without a true sort of evaluation of the imaging. And her MRCP actually was very characteristic of this starburst appearance that you can get on the CT, where you have a central calcification with a mixed sort of appearance, hypo and hyperattenuating and lesion. And on the characteristic thing on MRI is that it'll be on a T2 weighted study where T2 is where fluid is white, so that's gastric fluid on above, and then the cyst will be bright, as opposed to a pancreatic malignancy, which will typically be dark on a T2 study. And if it is removed, usually it's for symptomatic disease, it'll have these stratifications as well. On EUS, endoscopic ultrasound, these tend to be very dense in appearance, and that'll be a clue for it being a serous cystadenoma as opposed to a cystic lesion. So MRCP, they're bright, EUS, they're dense, and that sort of fits with serous cystadenoma. And on biopsies, if they'll be very bloody, but they can have glycogen staining cuboidal cells on a PS stain. Moving on to the neoplastic cysts that have malignant potential, you have the solid pseudopapillary neoplasm, which can be a mixed solid cystic lesion, typically in young women, and may be associated with liver mets. And when these type of cysts are found, these typically have high enough of a suspicion on imaging studies that one would either move forward with surgery because they're young women, or for diagnostic purposes, we could do an EUS for evaluation. The two big categories that we could sort of get into, actually, the main one will be IPMN, but the mucinous cyst would be mucinous cystic neoplasm as well as IPMN. Mucinous cystic neoplasms have an ovarian stroma in their origin, and they may mimic a pseudocyst, but the difference will be that when we sample them, they will have CEA elevation in addition to and a negative amylase, as opposed to an amylase that is high in a pseudocyst. So these will be typically in the tail, and these typically do require surgical resection given the risk of malignant progression. There's sometimes debate in a 2-3 centimeter cyst whether to observe or not, but in a young patient, generally speaking, we'll move forward with surgery. So the big category here, of course, is IPMNs. These are the ones that are the sort of challenge for everybody, whether that's primary care physicians, gastroenterologists, or pancreatic specialists, because these have this potential for malignancy, which can be hard to really determine. IPMNs can be classified essentially into two types: the branch duct IPMNs, where the smaller side branches are dilated, or the main duct IPMNs, where you have dilation of the main duct. These are some sort of stock images. Main duct would be defined as duct dilation greater than 5 millimeters, and side branch anywhere where you can start seeing a little cyst, even 2-3 millimeters, typically is a side branch IPMN, typically on an MRCP. And this kind of highlights the different sort of classification: branch duct, diffuse main duct, focal sort of segmental main duct, or mixed type where you have both. Generally speaking, main duct is associated with a higher risk of malignancy as opposed to branch duct IPMN. Now, these cysts will have different types of cells of origin if they are sampled at the level of the wall of the cyst or the duct lining, and those could be gastric, intestinal, pancreatobiliary, or oxocyntic, and the type of the lining actually predicts a risk for malignancy, so that the majority of branch duct types are gastric, which are not very high risk for malignancy, and it's the intestinal type of lining that is more associated with malignancy. The problem, of course, is that we can't really tell by EUS or by imaging studies which type of lining we have, so that doesn't really help us. It's more of a histologic area of interest. One thing that sort of is unclear is what is the true rate of progression. When you look at the guidelines, they will often talk about sort of ranges, and so I'm just quoting one of the main guidelines, the International Association of Pancreatology guideline, which talks about the risk of malignancy of 40% in patients with main duct IPMN, but this is in surgical resection specimens. So your denominator is patients who've already had surgery, as opposed to all patients with a main duct IPMN. So the perceived risk may be higher than what we think it is. And the same goes for branch duct IPMN. When you look at surgical series, high-grade dysplasia or cancer, 31%, with a range of 14 to 48%. And for cancer, 18% with a range of 6 to 37%. So it can be hard to really predict when a patient asks, so what is my risk of cancer? That's a vague, sort of typically a vague answer, but based on the data, we can say, well, the chances of you having it at the time of surgery in a high-risk lesion is relatively low, especially for main duct IPMN. And then the question becomes, well, how will it progress? And oftentimes we'll give a number or range of about 1 to 2% per year. But then they start doing the math. Well, in 20 years, my risk of cancer is 40%, which is pretty high. So should I have surgery? So it gets a bit confusing. So this was a nice study just published last year out of Japan, where they actually took patients who they were surveying for pancreatic cysts and specifically asymptomatic branch duct IPMNs. And they have 1,400 patients that they followed prospectively over the course of time and tried to determine their risk of malignancy over time. And what they found was that for all comers, the risk at 5 years was 3%, 10 years 6%, and 15 years 15%. In patients who had more than 5 years of follow-up, the 10-year risk was 3% and 15-year risk was 12%. So this is a bit more reassuring in a prospective high-quality study where they've followed patients over a long period of time to say that branch duct IPMN patients, we can reassure them, well, yes, you do have a risk, but it's not substantially high. At 10 years, your risk may be about 3%, and at 15 years, it may jump to 12%. This also highlights the potential importance of surveillance, which I'll come to when it comes to the guidelines. So what about diagnostic evaluation? Where do we go with these cysts once we have them? So usually the patients have had some sort of imaging study, either a CT or an MRI, and they've been referred to us. Generally speaking, MRCP is considered the best quality non-invasive study because it's so good for looking at cystic lesions. Some guidelines talk about CA19-9. I find that somewhat challenging to deal with because low-level elevations do come up and then we're lost with what to do. But the guidelines do talk about it, so one can consider checking those. And then the role of EUS. I'll jump to what we can do with the EUS and come back to when we should do it. But the primary sort of goal is to evaluate the cyst for morphology and then to consider obtaining fluid. I won't necessarily talk about cyst wall biopsy and confocal, where we actually put a probe to look at the lining of the cyst, because that was kind of out of the scope of this talk, I felt. In terms of MRI, obviously we're looking at the characteristics, the number, size, whether or not we can see an obvious communication with the main duct, and then we're looking for solid components. The resolution of MRI is 10 times lower than EUS, so we may not necessarily find a solid component on MRI, but that doesn't mean it may not be there. And we can't really classify the cyst because we can only have an appearance, we can't actually sample it. So that's where the EUS can come in handy. We can look at the size. It's a dynamic study. We can look for solid nodules or mural nodules. We can try and look for communication to the duct. I think for that, MRI is better. And then for sampling, we can consider it typically for cysts greater than 1 centimeter in size. Cytology historically has poor sensitivity, so we may have about a 30 to 50% chance of picking up malignancy. And to be honest, I think in real life it's even lower. Typically, we've checked CEA amylase. There's good evidence for glucose as a marker from Walter's group, amongst others. And then selected situations, we may do molecular testing and MSI testing, Proteonomics, various tests that I'm going to actually touch on just for interest purposes. And then we can look at the ampulla and recumulation. Does occur of these cysts. So the goal of cyst aspiration is not treatment, is actually just to do a diagnostic test. So the main test we have is CEA, which has been around for several years. And this is a study that showed that the area under the curve is about 0.8. And sensitivity specificity in the 70 to 80% range. So it's not a perfect test, but a cutoff of 192, higher than 192, is quite predictive of a mucinous cyst. So if it's a mucinous cyst, it could either be an IPMN or an MCN, and if the amylase is high, it's an IPMN. If it's low, it's MCN. Here's some work on the glucose. The glucose level of less than 50 has been shown to be more predictive of a mucinous cyst. So if in doubt, one could consider sending glucose off, and that's relatively easy to do. It could be done either bedside or via the lab, and that's another way to do it. The other area of intense interest in terms of research is similar to any other sort of neoplasm, this whole stepwise progression from normal to accumulation of genetic mutations leading to malignancy. The top side is the solid neoplasm pathway, and a proposed pathway for mucinous cysts would be on the lower side. So you have accumulation of KRAS, ectoin, and then P16 plus multiple other sort of genetic mutations. So a lot of work has been done on the molecular level, genome-wide sequencing, to identify genes that may be associated with malignancy. So cyst fluid could be sent for various genetic mutations. And as shown here, a table inspired by Walter's recent talk at DW, KRAS and GNAS are found in IPMN and MCN. VHL is very specific for serous adenomas, and then for solid pseudopapillary tumors, CTN and B1. These tests are available commercially. They cost about $750 to $800, and they are send-outs to institutions that perform them. What the Hopkins Group has done is actually take it to the next level to see if they can try and identify the higher risk lesions versus low risk lesions for malignancy based on molecular testing. At UCSF, some of the work that's been done is actually in proteonomics, where they've looked for enzymes that may be associated with differentiation of mucinous versus non-mucinous cysts. And gastrexin has been shown to be associated, and what they found was that associate along with CEA may have a much higher discriminant function than CEA alone. And they've come up with another peptidase, which also has been shown to be beneficial for distinguishing high-grade versus low-grade mucinous lesions. So there's all this molecular work being done on the cyst fluid to try and identify high-risk lesions versus low-risk lesions. In summary, I would say that amylase, CEA, glucose should likely be baseline tests, and then based on level of suspicion, additional tests could be ordered, typically send out or in the setting of a research study. And just to sort of wrap it up, also similarly, MSI testing has been performed. Pancreatoscopy and main duct IPMN, I personally, even though I enjoy doing ERCP, I'm not a big fan of, because I think by that time your level of suspicion is high enough that I'm not sure what it really adds. And on top, there's a risk of causing pancreatitis. There was a patient with papillary stenosis / IPMN. We're trying to figure out which one it is, did pancreatoscopy. Our level of suspicion for IPMN was relatively low and ended up giving him pancreatitis. And since then, I personally don't feel that there's good sort of justification in patients who are typically asymptomatic. So I try to avoid doing ERCP. So the guidelines, I want to keep this brief and to the point, but our challenges are that there is a risk of malignancy. Cysts, especially asymptomatic ones, cause a lot of anxiety for patients and physicians, and oftentimes everybody's unsure what to do. But the key points here are reassurance is really important. Knowing that guidelines exist and just getting a handle on the summary of those guidelines is important. And just saying that we need to focus on the high-risk lesions. We will continue to survey them and continue to reassure patients. This slide actually, in some ways, says it all because we have 5 major guidelines with differences, which highlights the problem that there is a lack of consensus amongst different societies, different groups of people. And while they overlap in several areas, they do tend to have differences. I will say the AGA guideline has a different focus. It has a focus on asymptomatic cysts, typically smaller than a centimeter, which is different from the other guidelines which talk about larger cysts. But essentially, all guidelines do this. They will divide these cysts into high risk or low risk findings. So patients who have high risk features for malignancy, i.e. symptomatic disease, main duct greater than 6 to 8 millimeters, for instance, lymphadenopathy, duct obstruction, mural nodule, all these would be considered high risk, and these will either require intense surveillance or they'll end up requiring surgery. The low risks tend to be cysts that just need to be followed. So then you have these pathways based on each of the different guidelines, and this is the revised Fukuoka International Consensus Guideline, and obviously it's too hard to read here, but the thing is they start with high-risk stigmata or not, yes, no, yes, go down the surgery pathway, no, medium-risk stigmata, yes, medium-risk stigmata, okay, then let's figure out what to do, and oftentimes that road leads down to an EUS pathway. So then you go to EUS, and then you look for various high-risk features, you can send the fluid off, you can do various things, and decide which way to go. If they don't have those, you can continue to then take them to the surveillance pathway. So what are the high-risk stigmata? I just mentioned them earlier, and each guideline varies in what they feel is the most important thing, but there's significant overlap in terms of duct dilation, lymphadenopathy, mural nodule, etc. The recurring theme, different guidelines, I wish this could be simplified to a single document, but that's not the case. And then the question becomes, should we EUS or not, right? And that really boils down to the size. Based on this one guideline, the less than 1 centimeter can be monitored with MRI or CT. 1 to 2 CT, MRI, and you can shorten the interval. 2 to 3, you can do an EUS, and greater than 3, you need to do very close surveillance. This size criteria has changed over time. We were doing EUSs at less than a centimeter. A lot of us in our practices have stopped doing EUSs at that size. 1 to 2 may be considered. It's also driven by patient anxiety, in which case we may do it. But usually it's in the 2 to 3 range. And then the timing of surveillance has also changed over time. The time interval continues to increase as the guidelines get updated, as we realize that these cysts are not as malignant as we used to think. And by extension, surgery is also being done less frequently. The one sort of caveat, I guess, in all this is that the AGA guidelines will say that for a cyst less than a centimeter at 5 years of stability, so every 2 years you do an MRI, and at 5 years you can stop surveillance on a less than 10 millimeter cyst. A lot of people have issues with that particular recommendation. I personally, and this is not evidence-based, but just sort of logically in my mind, it doesn't sit well with me, especially for young patients. And they never really, I will say that if I offer it to them, perhaps it's in the way that I offer it, but they will decline that offer and usually want continued surveillance. Excuse me. So to summarize, pancreatic cysts are common and a source of a lot of anxiety, but as is often the case, the more we get familiar with them, the less anxiety we have. Malignant potential varies. Mucinous cysts are the key things to worry about. EUS with cyst analysis may be indicated in larger cysts, and CEA cytology and glucose, I think, should be mainlined with additional tests as needed. And a knowledge of the different guidelines and the overall big picture is important for most people practicing GI. I think, if in any doubt, obviously these should be referred to colleagues, whether that's pancreatic specialists, surgeons, and reviewing with radiology. Sorry, I went over my time. Thank you for your attention.
Mustafa, that was a great summary. What is your opinion about, lately there have been recent endoscopic developments or devices, including advancement of the core biopsy needle, including the Moray forceps, as well as confocal microscopy. Do you have any experience with these, and have they changed your practice or approach on cyst management?
So I do have some experience. I have anecdotes, which usually, when I come to these meetings and I hear the IBD talks and the colon cancer screening and surveillance, and then we in our field start giving anecdotes. It's really concerning. I will say that the data for Confocal is at best mediocre in my opinion. I think it can help. The issue is if you have a cyst like this and your needle's coming in at an angle, you can survey about, maybe a third of the cyst. So I just don't see putting a 19 gauge needle, then putting a probe in, exposing the patient to risk of pancreatitis. If you're suspicious enough of a cyst where you're wanting to decide whether to operate or not, I think there may be other ways to go about it with imaging. With respect to biopsies of the lining, I have similar issues. But I did have a patient with a liquefied cyst. It ended up being a neuroendocrine tumor, so I think it has some role. And I'm trying to remember what the third modality was.
The Moray forceps?
Yes, that was the forceps. So confocal, I'm not sure. Moray forceps, again, very select situations. I think by the time you're doing this, your level of suspicion is already gone from medium to medium high. And the question becomes, should we be doing that versus pursuing molecular testing and relatively less invasive testing modalities and then pushing for these aggressive EUS approaches?
Yeah, and I'll just say anecdotally, I've heard from other colleagues as well as Raman at UCLA had published a little series, and indeed a couple of years ago, something we were all doing, we were aspirating the fluid, the cyst lining then collapses, and with a higher belief in the core biopsy, then going through the wall that way to try to get a tissue diagnosis or try to identify high-grade dysplasia. Have you tried that?
I haven't directly tried that. I have tried FNBing or FNing nodules, or what I think is a nodule. And I can, again, the issue becomes, when I've done it, I've seen blood. I've had at least one episode of pancreatitis post-sampling. And that just dissuades me from doing this because we're taking asymptomatic patients and doing it. So I personally, as much as I love ERCP and interventional EUS, in this realm, I think we can do too much to get to an answer and give the patient a problem which doesn't exist. So personally, I have not done it much, but I am aware of Raman's sort of experience, and I would say that I would approach with caution.
Thank you, Mustafa. Very nice overview. Also, anecdotally, I think one thing that comes up relatively often and surprisingly is that when we have patients with pancreatitis and presumed inflammatory pseudocysts, but potentially some unusual characteristics, in particular, like clear history of acute pancreatitis or just no risk factors for pancreatitis. Occasionally, we'll still sample these cysts, even though they look inflammatory. And then we see very high CA levels, like over 1,000 in many cases. In that scenario, I mean, is there anything specifically that makes you just sort of go ahead with cyst gastrostomy and then potentially sample the wall after drainage, or have you used the Moray forceps in this instance? And then I have a second question, but I'll hear that first.
Sure. Again, I'm not a big fan of sampling intracystically. I just conceptually I find it traumatizing for the lesion and potentially for the patient. So in those settings too, again, I'll stage it. I'll do an EUS, aspirate the fluid, send it off. And because if I do a CEA and it's high, we have our answer. And part of it is also being there, with the molecular work being done or the proteomic work being done, we would sample, collect for that purpose. So I personally have not done it, but I can see the argument being made to do the Moray forceps in those settings.
Mm-hmm. Do you ever ignore a high CEA if it looks like an inflammatory pseudocyst clinically?
I can't do that just because of the implications. Even though the specificity is not high, I think we still have to follow it with some sort of imaging study. And usually it has to take like a year or two for us to finally say, okay, it's stable, maybe we can just sit tight on it. Yeah. So I don't completely, one time on any of these, it's very hard to just say, okay, we're done here. Oftentimes patients want reassurance. Even the serous adenoma patients with a 6 centimeter lesion want reassurance because they will have Googled and found that serous adenocarcinoma can occur. So therefore, I think all these patients do need reassurance. And I think in the scheme of things, us telling them that it's going to be okay for the most part, and then just following up with an MRI is not a bad thing rather than putting them through invasive tests.
Okay. And then the second thing I wanted to ask you about is, all of these guidelines seem like they sort of fall by the wayside in high-risk surgical patients. So I think oftentimes we end up doing surveillance on cysts that have very high-risk features, in particular significant interval growth, potentially some nodularity along the cyst wall. But unless there's a diagnosis of cancer, the surgeons still don't want to touch it in certain patients. So in this scenario, do you think there's any role, or have you ever been able to convince yourself that systeblation is worthwhile or worth the risk of pancreatitis?
Yeah, I didn't get into that. I think there is a role, and I think it's going to be evolving. There is as you, I'm sure, know, that there is a study out of Indiana, and I believe somewhere on the East Coast, but I forget, where they're actually doing a prospective NIH-funded study to look at the role of systeblation. I believe it's paclitaxel and saline. So I think there will be a role at our institution. To date, there has been reluctance for us to do that, so I haven't pushed it too hard because of the lack of data. But I think that in terms of the future, potentially that may be a role that we play for the management of these cysts.
Thank you.
Okay, thanks. Thank you.
I'll echo a thank you, Mustafa. It's great to not just be reminded of the guidelines, but to hear expert opinion and interpretation of them. So we have one more talk. Thanks for sticking around. I think you're going to enjoy this one. And I'm going to preface it by saying, at the NCSCG in my tenure here, which is 5 years now, we've really had a shift towards reaching out to all parts of the field of GI. That includes fellows. You've seen posters. We have a monthly webinar series, thanks to Robert Wong. And that includes our colleagues who are APPs, Advanced Practice Providers. We have a subcommittee for APPs now. We've included them more and more as we do in our own practice. So it's in that context that I'm excited to introduce our next speaker. I think you'll find her background to be unique, and as I read through her CV, fascinating. And so I'm going to share a little bit of that with you because it won't be part of her talk, I doubt. So Josefina Gomez started out with her BSN in 1989, and then one of the first things she did was work in one of the first San Mateo AIDS programs, and that was one of the first clinical experiences she had. She's done med-surg nursing, she's done outreach nursing. Her home outreach nursing was actually in part in the Northern Marianas Islands, which, if you need a refresher, is about 100 miles northeast of Guam. And so her clinical experience really is unlike, I think, what a lot of us have. And she brings that with her now as she completed her master's in nursing in 2001 at UCSF and has moved into the field of GI over the last 10 to 15 years now, first at Stanford, now at UCSF. So she's really approaching the same thing that you're seeing every day with similar expertise but a much different background, I am assuming. And so with that in mind, we really welcome Josie to talk about a more common topic, which is heartburn and the use of chronic PPIs. Thanks, Josie.
That's a joke between me and the gentleman who put that on. I sent my slides up a little bit late, and he said, I'll put it on there if you sing. So, of course, I said the devil went down to Georgia. I didn't know he could actually sing it. So I thank you so much for that kind introduction. I think that you might have a check from my mother coming. One small correction, I've been in GI for 9 years, 5 at Stanford and 4 at UCSF. I'm so pleased to be here and count myself or be amongst such learned and kind colleagues, even though I feel like an anecdote in a room full of randomized clinical trials. Okay. So the GERD and the cost of PPI, it's huge. So, okay. I was told not to look there, but it's okay. So So when you look at how much we're spending on PPIs, it's huge. In 2020, it was estimated that we spent $2.7 billion. And am I going back and forth with the sound? Sorry. Sorry, I'm kind of a newbie at this, and it's showing a little bit, so I apologize. It is. Okay, I should just do that. Okay. All righty. See, anecdote. So we spent $2.7 billion in 2020, and it's only anticipated to go up such that in 2026, we're going to be spending about $3.5